Okay, hello everyone. Welcome to today's episode of Physician Pathways. Oh, and we have lost Dr. McCoy.
Oh, there we go.
Okay.
Sorry, I hit the wrong button.
No worries, no worries. On today's episode, we have Dr. Bridget McCoy, who is a forensic psychiatrist. Dr. McCoy, thank you so much for joining us today. To start off, can you tell us a little bit more about yourself and a little bit about your training?
Yeah, sure, of course. So I actually am originally from the St. Louis area. I grew up in the suburbs of St. Louis. And then I went to Fontbonne University for my undergraduate, and then which is in St. Louis for people who aren't familiar with the area. It's a small little liberal arts college right across the street from WashU. And then I left and I went to the Chicago area for medical school. I did medical school at Chicago Medical School at Rosalind Franklin University. So I stayed there throughout school, and then I went to the Bronx. I went to New York City for my psychiatry residency and stayed there for a year after residency for my fellowship in forensic psychiatry. Then after forensic fellowship, we had decided that New York was not the place for us, and we were enjoying our cities and our gradual increase in city size up to New York, and then decided that that was a little too much city. And so we took a sharp turn and went to New Mexico. And so moved to New Mexico from New York after training, and lived in Albuquerque for a little while. And there I actually worked at the University of New Mexico for a little bit. And then I worked at a jail in Albuquerque for a little bit also, and spent lots of time outdoors and enjoying wonderful, beautiful weather. But decided that we wanted to be a little bit closer to supports. So came back to the Midwest, and SLU St. Louis was a great fit for me because we have a forensic fellowship and a forensic division. So yeah.
That sounds perfect. It must be nice to be back home too.
Yes, definitely. Most of my family is still here, so it was nice to come back home and be around all those folks for sure.
Yeah. So I know you mentioned that you worked at a jail, but for the most part, we were just talking before this, and honestly, we don't really know what a forensic psychiatrist does. So do you think you could tell us a little bit more about that and kind of like your day-to-day life?
Yes, although I will tell you, this is going to be the theme of my answers related to psychiatry, is that it's really varied depending on the individual and what they decide and want to make their path. So the fellowship training is a year long, and you do a number of different things in the field of forensic psychiatry. It's kind of largely broken up into criminal forensic psychiatry and civil forensic psychiatry. So, and it really covers anywhere that the legal system overlaps with the mental health system. So in my fellowship training, I rotated at jails and prisons. So I spent some time at Rikers Island and spent some time in Sing Sing in New York. And there so some forensic psychiatrists are just treating folks in correctional settings. So that might be kind of their path. All correctional psychiatrists, though, aren't forensically trained, but that's a path that some people who are more interested in kind of that overlap would go down. So that's part of the fellowship training. And then you do a lot of learning about evaluations as a forensic psychiatrist. So primarily I do criminal forensic psychiatry, and my evaluations are seeing people to determine if they're competent to stand trial, and seeing people to determine like criminal responsibility, like if someone may be found not guilty by reason of insanity. So those are some of the bigger assessments that happen on the criminal side. On the civil side, we'll get psychiatrists involved for like evaluations for people who are saying that they have PTSD from certain interactions and are now emotionally harmed and are suing someone for damages. We'll get involved in fitness for duty. So like to see if people are if people are having difficulties at work, their employers might ask a forensic psychiatrist to do an evaluation to see if they are fit to continue their work. And then there's some more kind of overlap in the child forensic world. So really, I've just touched on like a couple of the areas that you can work in. And it goes beyond that for sure. So my work has changed everywhere that I've been. When I was in Albuquerque and I was working in a jail, it was just like a regular clinical job. And I went in the morning, Monday through Friday, with call and all that, and saw patients it was kind of like an inpatient psych unit in the jail. So we had units that were for people who had serious mental illness inside the jail. And so I saw patients there and treated them. And that was my role. But I also worked as a consultant for the state mental health, the State Department of Mental Health in Albuquerque. So was involved in more of an administrative role, working with them in their competence to stand trial evaluators across the state. So doing like trainings and doing some legislative stuff and kind of some administrative oversight.
Okay.
No, that's
a lot. No, I needed that.
No, that sounds super cool. I mean, I guess did you have a question?
I did have a question actually following up. You briefly mentioned your on-call schedule. Do you think you could talk a little bit more about that in, I guess, your residency and also forensic psychiatry?
Oh, sure. So in my residency, gosh, you have to make me go back to, I was only thinking on call for now. I can't remember all the way back then.
It's okay if you just remember now.
But my on-call for residency wasn't bad. And I think it's kind of similar for the residents here in psychiatry, that like first year you do maybe like one evening a week, but you do a fair amount of evening call, and then weekday call, but no overnight calls. And then usually second year and third year are heavier with some overnight calls. I didn't have any call my fourth year during my residency. It was amazing. So we did evening and weekend on first year. I am remembering, yeah, it's coming back. And then second and third year, we did overnight call in the emergency department and then covering the hospital. And then, yeah, fourth year, I didn't have any call at all. And I would say most residency programs are pretty light on call in fourth year for sure for psychiatry. And as an attending, so for myself, when I was at UNM, I didn't have any call. Obviously there were people that had to work outside of regular business hours, but it was all volunteer, and you got paid extra. So people volunteered for it. So I didn't have to take any if I didn't want any. For my job at the jail, there were 5 of us. And so someone would take like call by phone for a week straight. So like evening, overnight, you'd be on call by phone, but you would never have to go in during the week. And then you went in to round that weekend. And so that was once every 5 weeks, and you got paid a little bit extra. And now, you also get paid to come in for weekend calls. I have an evening call that's just a phone call about once every other week or so. And then on the weekends, it's kind of dependent on how much you want. Everyone has to do a little bit, but some people are asking for more weekends because you get paid more. So like, I did one in February and I don't have another weekend until June. So it's quite flexible, and varies depending on the setting that you're in. Some people will look for jobs where they don't have any call at all, and that's what they want, and that's what they'll find, and that's not hard to find. And some people are fine with taking call. Most of the time, at least part of the call is going to be extra pay.
Yeah, and well, I had a follow-up question about, and if the fellowship years in forensic, so like what how would you distinguish between the role of a psychiatrist versus like a forensic psychiatrist? Are there things that you're able to do that, you wouldn't be able to do just after the residency?
Yes. I don't recommend anyone practice any of the difference is that unless you're just working in a clinical setting, if you're doing like I work with the public defender's office now as a forensic evaluator. If you're going to be doing evaluations, you should have fellowship training, because you're not versed in the legal system, and it's an entirely different approach. You're not a treating clinician anymore. So all of your residency was about learning how to treat patients, and the role changes, and you're meant to be an objective evaluator, and the client is the court. The client is the legal system, or the client is the attorney, rather than an actual patient that you're supposed to be like advocating for or treating. So it's a whole different kind of frame of what your role is, really.
Wow, that sounds really cool. I think it's a very different approach than we've been taught. Do you do both? Do you do like patient care as well and like an evaluator's role?
I do, yeah. So at SLU, I'm technically full-time clinical. So I work mostly on our acute inpatient unit. I do a little bit of consult work, like just like consult work in the general hospital. But mostly I'm working on the acute inpatient unit at SLU. And so I do that full-time. And then I do forensic evaluations on top of that through the forensic division at SLU. Yeah, so two different roles.
And so, okay, I'm very curious on like what drew you to the specialty, and like were you deciding between specialties, and like what was your process?
Yes, I was deciding between specialties. I have no one in medicine in my family. I have no one in mental health in my family. So medical school was like and my undergraduate degree is in English literature. So I thought I was going to be a teacher, then decided I wasn't going to be a teacher, and I wasn't sure what I was going to do. So I went to medical school thinking more maybe like sports medicine kind of stuff. I was interested in anatomy. I've played sports all my life, and I was kind of like interested in that before I even thought about trying to go to medical school. And then once I started to get into my clerkships, I actually did surgery as my first clerkship, and I loved it. Trauma surgery was like my favorite thing. And I did my psychiatry rotation. I can't remember, it was either right before Christmas break or right after Christmas break. And that was and so after I did that one, then I was unsure of what I wanted to do. And I think I liked the black and white aspects of being able to solve a problem in surgery. And I liked kind of the crisis and the unknown related to trauma surgery, and kind of that like always being on and always going. And in psychiatry and in many other clerkships, I struggled with not being able to really get to know a person or spend enough time with a person and understand all of the things that were actually impacting their medical issues. And so that led me to being interested in psychiatry, where I got to spend all this time with people. And I've always really just been interested in the human story and how people kind of go about their lives and interact with others and kind of make it in the world. So psychiatry gave me that. And then ultimately it came down to some about work-life balance and not wanting to have the call of the trauma surgery all the time, and then getting to the idea of like, well, I could do a different kind of surgical specialty that was more structured and routine. but acknowledging that that would be too black and white for me and then become too rote, where psychiatry is always got some sort of curious, unknown gray area that I can try and sort out and figure out and be surprised by.
Yeah. It's like, it's very interesting. I think that's my favorite question to ask. It's like, I mean, we know that like so many people change their mind going into it, but it's really interesting to see like how people like work through like what they're interested in. And then from there, like, I don't know, to me, like trauma surgery and psychiatry are two very different things. But when you put it like that, I'm like, wow, that does seem similar. So yeah, no, I'm excited. I feel like as an M1 too, like we really don't know much about anything.
About
So
it.
it's
Yes.
nice. But okay, so what do you love most about your job? And on the flip side, what do you like least about your job?
Can I give more than one? Does it have to be one?
Everything that you like.
I really, so like just setting wise, I really enjoy working with trainees. So I specifically residents, because I get really excited about psychiatry and forensic psychiatry. So if anyone is really interested in forensic psychiatry, I can sit and just like talk about it for a long time. So I really like being able to work with people who are in that like excited growing process. Work-wise, probably, I mean, so I work on the inpatient unit. We have really sick folks there, and seeing some of our sickest people make big changes and have good outcomes is probably the thing I love. I love best about my job. That's probably also what's hardest about my job, because the percentage of people that I can get there is smaller probably than the percentage of people that I feel like I can help some, but have a lot of limits in our resources and legal system, societal supports. So things that just sometimes it will feel hard to make movement with people who are chronically ill and in patterns where they are just having the same pattern, and I can't make a change in that. And I think that's the hardest part of what I do.
That does sound tough. I feel like that's what I think about when I think of psychiatry is like the toughest part. But I think we kind of touched about this a little bit when you talked about your move, but how does a specialty change, or how does what you do change based on where you are? So like if you're in like an urban setting or a rural setting, and things like that.
So it changes, I think it changes drastically depending on if you're in an urban setting or a rural setting. For psychiatry, it changes just depending on what state you are in, because there are different laws that guide each state as far as like who you can hospitalize at what point and for how long and for what. So just in of itself, like the laws will be different, and you have to learn those if you move from one state to the other state. I think one of the other things that really is, and I can use my 3 states. So I don't really count Chicago, even though I did my medical school there, because I had a limited exposure to psychiatry while I was in Chicago. But from New York to New Mexico to Missouri, New York is very resourceful. So I could see a person in the emergency department in New York and decide that they didn't need a psychiatric hospitalization, but I could discharge them, and a social worker would follow up with them, and they would have an intake appointment with a psychiatrist in less than 5 days. I moved to New Mexico, and that wasn't happening ever. I was discharging people from the emergency department with a list of resources that they could try and call sometime, but even I would call and not be able to get someone in for many, many months. And I didn't even have a social worker that worked in the psychiatric emergency department to try and help with any of those things. And then I moved to Missouri, and Missouri is kind of an in-between. We have much more, but there are still limitations in what you have available. And that I think changes also. I think that's kind of reflective also of urban settings and rural settings. So Albuquerque is a city, but New Mexico in general is rural and resource poor. So that will impact your ability to practice and how you practice for sure. Psychiatry also seems to have like some different approaches to practice based on the coasts. I interviewed out on the West Coast and on the East Coast, and the East Coast is much more like previously based in psychoanalysis, so it has like a strong psychodynamic kind of core, and the West Coast is much more biological, medication minded than therapy minded. So there's just variations depending on where you're at, which I think is interesting also.
That's super interesting. I would never thought that. But we have a question on the chat as well, so maybe we can go on that. So Katie was asking what goes into an evaluation and what do the evaluations look like?
Can I ask a clarifying question? Are you talking about a forensic evaluation or just a regular psychiatric, like clinical assessment?
A forensic evaluation.
Okay, that's what I thought. In general, it's going to be different, obviously, for the specific evaluation you're doing, but like in general, I will get a referral from an attorney. I'll talk to the attorney about their client, about what their concerns are. I'll get some information from the attorney. And then for the ones that are like criminal cases, I'll get materials, I'll get legal materials, and then I'll get medical records to review beforehand. So I'll have information about whatever case they're currently being charged with, and then whatever medical records are available that might be pertinent to the question that's being asked. And then I'll review those, and then I meet with the person, the client. And the evaluations really vary, but they're much longer than general like clinical assessments. So I would say my shortest for someone who's actually participating in the evaluation is maybe an hour and a half, but probably closer to 2 hours. And sometimes it will take upwards of 4 hours or coming back multiple times. And you're really just doing kind of an extended clinical psychiatric assessment. So I start with like childhood. I ask about how she grew up in relationships, how you got along with like what discipline was like, how you got along with people, who were your closest people when you were that age, what was school like, what were friends like there, did you get in trouble in school, how'd you do in school, if you dropped out, why you dropped out, and on, and then employment, relationship history, so all of that, and then psychiatric like symptom history, and then I ask questions pertinent to whatever the like attorney's question is. So after all of that, then if there is a question about their competence to stand trial, which just means like their understanding of their current case or the legal system in general, then I have kind of a set of questions to help me assess what their understanding is of all of that, how they interact with their lawyer. And so I have another set of questions that I go through. And sometimes it involves some cognitive testing. Sometimes it involves some malingering testing to see if someone might be feigning symptoms. And then after I'm done with the whole evaluation, I kind of compile my thoughts and let the attorney know what I'm thinking. And then I may be asked to write up a report based on that would go to the court. So it's quite a process. I find fascinating. I get to learn like really someone's story for sure. And then whenever I do the evaluation, I just get to ask loads and loads of questions. I get to try to understand every little detail.
That's very interesting.
Mm-hmm.
I kind of have a follow-up question too. Do you ever interview, so you talk to them, but do you talk to, like, let's say they mentioned like they dated someone for like 10 years, like would you also have to talk to them, or like a parent, or do you just talk to them and make your decision?
It depends on what the question is. it depends on what the question is. So oftentimes I'm just asking them, but sometimes I have like records, like sometimes I might have legal records of people interviewing other people that were involved in the case or other people around them. And sometimes I will get collateral information depending on how reliable the person is and how much other collateral information I have based on records and their legal history, and then exactly what the question is. Definitely if there's discrepancies, like if there's a competence question and I think I have a feel for it, but what the person is telling me seems to not fit with something in the record or something that I'm seeing and what they're saying, and I can't figure out exactly why, then I'll definitely get some collateral information.
Wow, that sounds like a really cool process. I just yeah. I kind of wanted to ask a little bit about, we touched on this a little before, and I was very curious on so when you mentioned that, you know, you don't like so much that you can't help people, or you can't help people in the way you want to sometimes. And so I'm actually interested in oncology, which I feel like a lot of people tell me the same thing about, like, you can't, you know, just give someone a drug and then they just walk home and they're like cured or something like that. So how do you kind of deal with that when, you know, you feel like you could have done more, but, you know, just like the condition is such, or the person is such that you know, this is the best that you could do?
Mm-hmm. That's a great question, and I don't have a specific answer to it because it's evolving all the time, because it impacts me in different ways. I mean, sometimes I think it takes an emotional toll on me if it's a particularly challenging case, or if I feel like I'm having like a lot of that kind of all at once. I think one of the ways that I kind of process it and that it's helpful for me at work is when I can have some of that, but then have a case or two where I am seeing some kind of change or some kind of improvement. And that kind of can help bring me back to the good and the purpose and the goal. I go for lots of runs and kind of work through some of my struggles with it and difficulties with it that way. I find, and this has been kind of an ongoing search as I have moved around, but trying to settle here in St. Louis, finding a collaborative group of colleagues. I have some from like the different places that I've worked and trained before, but I've been getting kind of a group of colleagues here that are good supports to kind of talk about some of those things whenever you are struggling with that, and to work on other projects that might not impact that one person that I'm struggling with, but that I can work on to make change in other areas where I feel like change can be made, I think, are all the different ways.
That's cool. That's really cool. I personally was very curious about that aspect. Well, taking a sharp pivot, so looking back, is there anything that you wish you'd known or done differently during medical school or residency?
I have to tell you, I reached out to a group of co-residents that I'm still in touch with today to ask them, because I saw this question and I was like, I just don't know the answer to this question. And I don't know the answer. Much of what I've gotten back is just trying to remember, which you guys have already said, to be open-minded as you're going through the process, because lots of people do come in with an idea of what will fit them or what will work for them. And even if that's your mindset, like, that's fine and great. And we all have our ideas about who we are and what we're going to do in life, but trying to be as open-minded as possible, because people will be surprised by clerkships and what really sparks something in them. I think psychiatry is broad and varied, and there are a lot of different things. There are a lot of different areas to practice in, and they are quite different. So like if someone deciding to go into private practice outpatient psychiatry versus, city inpatient unit or city emergency department, those are two drastically different lifestyles, patient populations, different types of clinical stress that you're dealing with. And the experiences you get through clerkship might not allow you to see kind of a number of different settings or different areas that are possible in psychiatry. So if there is any kind of interest, I think recommendations to see as much of it as possible. And if people are interested then in actually going into psychiatry, thinking about electives. Palliative care is so electives outside of psychiatry that can be helpful. So things like palliative care might be really helpful. Anything like having to do with pediatric development, because you don't get as much of that like developmental stuff in psychiatry. That's really important for understanding human beings. I did a radiology, like a brain radiology course that was really helpful. And so just kind of being creative with what kind of electives you might be able to supplement yourself with, I think is what I come up with. That's my advice.
Thank you. That was really nice of you to ask your co-residents. I think that's a good question though. I always like hearing that, especially as someone. But kind of going off of that, what should a medical student who's interested in going into psychiatry be doing now in order to make themselves more competitive to get into residency?
If you are really interested and want to get involved in any projects, then getting in touch with anyone from the psychiatry or psychology department is always helpful. The psychology department here is great, and they're always the neuropsychology department works closely within the psychiatry department. They have like a clinic in our clinic, and they're always working on research projects also. So that can help get you just connected to some people and get you involved in any kind of projects that will be helpful for you CV wise, but also helpful for you just like to kind of explore what your interests are. So I think that's the biggest thing is if you are interested or you're pretty sure you're interested, then trying to find little areas where you can explore that a little bit more and to see maybe other aspects that you don't know about the field that might be helpful for you for your decision making, and then also just to make you a little bit more broadly versed in the field.
Cool. Yeah. Thank you so much. That's like really helpful advice. And I also wanted to ask, like, what does your life look like outside of medicine? And you also mentioned a few projects that you do outside of patient care, and I'd be really curious to learn more about that as well.
Okay, I'm going to start with.
So that's a lot. I asked like 5 questions. I'm so sorry.
We'll start with work, because then I can get that done and then talk about life outside of work. Projects I'm working on right now. I don't have any like large scale projects, but a couple of things I've worked on over time and will continue to work on. Developing curriculum to help teach residents about firearms, about access to firearms, about counseling people on access to firearms, which is not something oddly that happens in psychiatry residency, although you're asked to do it all the time. In New Mexico, I did a number of things in New Mexico when I worked at UNM. It was a whole lot of all over the place, but one of the things I did was I worked with the Albuquerque Police Department, and I really enjoyed working with the Albuquerque Police Department. So I've only been in St. Louis for a little bit over a year, but during that time I'm trying to make some connections with the police department because I would like to have a more collaborative relationship with them. And more connections with substance use treatment programs in the area and working on substance use treatment for inpatients at SLU. So related to my clinical care, but substance use is a big part of what I think sometimes makes those patients very challenging whenever they're coming in and coming out. We don't have a lot by way of substance use treatment, but also by way of things like actual access to housing or actual access to skills that are going to help them find employment and then get themselves on a path, because those are the things that are actually important to them at the time, not so much the medication that I may be able to prescribe to them or not prescribe to them. So I've been working on trying to build some relationships with community partners that are interested in those things. Long term, since you asked, long term and related to forensics, in New York, one of the things I did during my fellowship was I worked for a program doing evaluations for people who might be eligible for a diversion program. So instead of going to jail or prison, to participate in a treatment program in the community. And I would love to, I think that they have a little bit of that here, or they have had it in the past, but it does not, from what I can gather so far, it doesn't seem like it's very robust. And I would love to get some involvement in that and try and make that an actual, like, fully functioning program. And outside of work, well, as I mentioned, I have a dog, so I love hanging out with my dog. As I mentioned, I lived in New Mexico and loved to be outdoors, so we don't have exactly the outdoor spaces here that we had in New Mexico, but try to get outdoors as much as possible. Yes, as much as possible, hiking, biking, running, any of those things. And my husband is actually a carpenter, and we are building a shop in our house, our backyard right now. So I spend a fair amount of free time doing that right now also.
That's exciting.
Yes, yes.
Okay. So kind of taking another pivot. Can't be done with work yet. Katie said she's not too sure if you're able to answer this question, but if you were able to, talk about a specific case that stood out or has stuck with you throughout your career and why.
Sure, I can answer that question. I'll ask again though. Are you talking about a clinical case or a forensic case? I probably can't talk about a forensic case that has stood out to me.
And I guess the clinical, whichever one.
I mean, I could maybe if I thought about it for a forensic case, but I can tell you a little bit. Yeah, it won't be exactly, but so in my residency, we actually spent 6 months working at a state psychiatric hospital in New York in my residency. And the state hospitals there, I think most of them have a mixed population of civil patients and forensic patients, which means civil patients are just like a person off the street comes into, like, they come into SLU and they get hospitalized on our inpatient unit, but they are very sick and they need a long-term hospitalization. Then in other states, they could be transferred from that acute unit to a state hospital unit. So we had patients like that. So we had some patients who had been there for like 20, 30 years. And essentially they were just civil patients that lived in the hospital. And then we also had patients who were criminal patients that had already been through the system for a long time. So the majority of them had been found not guilty by reason of insanity. And they had then gone to a high security forensic hospital and probably spent somewhere between 5 or 10 years there. And then they go to a lower level, medium security hospital and spend another 5 or so years there. And then eventually go to the civil state hospital and probably spend another 10 plus years there. So I was at that hospital, and so the majority of my patients had been hospitalized 15 plus years. So that just in general, those are the patients that like really stick out in my mind quite a bit, because that's a different kind of patient that you don't see everywhere else, and you certainly don't see for that long of a period of time or period of stability. So I ran a forensic group there, and it was all males, and again, all of them had been there for decades. One of them, I'm not going to remember the exact details, but he was the leader of the group. He was like the patient leader of the group. And he was, so they have to like go up for different aspects of their release. And eventually they're looking for a conditional release, which means they would leave the hospital, but they would still be monitored by the state. So he was going up for conditional release, and he thought he was probably going to get it. But I can't remember how long he had been hospitalized, but I want to say like 30 something years. So like we spent our time in forensic group talking about how he was going to navigate the world, talking about how to use the subway, talking about how to use a cell phone, talking about how to use the internet. Like he had a little bit of access to some of those things, not a cell phone. And it just is really, it was really striking to work with people like that who had been there for that amount of time, that period of their life, and then to try and think about how they can navigate transitioning back into the world.
Wow, that's a lot. I did not know.
I didn't know
Not know
people
that.
lived at a hospital for that long.
Yeah.
That's a lot. Katie, did that answer your question? I thought that was really interesting.
Yes, thank you.
Yeah.
Okay, and then one last question for you. And that's just, do you have any last pieces of advice for us or medical students in general?
Just be curious. Be curious.
Sorry, we've like exhausted you to the
I
point
know.
of saying nothing else.
I got nothing. I'd say be curious, be open-minded and be curious. And that's through medical school and residency. I mean, those are the things that are going to get you excited and get you to find out like what you're really interested in, and find those little paths for yourself, and reach out to people, utilize other people whenever you're at this stage, to ask questions and get the support that you need, and help you try and figure out that path. Yeah, that's all I got.
Awesome. Yeah. Thank you so much, Dr. McCoy. It was really it was very nice talking to you and just learning so much about a field that I personally had no idea about. And I guess if no one else has any questions, I think we can end here.
Facebook.
Yes.
Thank you so much.
You're welcome. It was a pleasure talking with both of you also. Thanks for having me.
Yeah. Thank you so much.
Thank you.
You're welcome.